Okay, hello guys. Hello. Okay, welcome to a session. After a long period of time, we came again, right? I think it's going on, right? Yes, it's going on. Okay. So previously we stopped it where anaplastic carcinoma of thyroid. I think we stopped there. If I'm not wrong, we stopped there, right? Okay, I thought of like you all had your revision. If you are on track, I'm thinking like you're on track, you're going with all your revision as perfect as it's like. Okay, so one of the doctors has asked me this question. So I just forgot the name of the doctor. Sorry, doctor, if you don't mind. But I remember his question. The question is like, doctor, how absolute or how accurate are marrows or dams tests? So one of the doctor has asked me like this. Wait, we'll keep this in a different notebook. So I don't want to disturb this. So we'll just keep this in a different notebook. So let us keep it like this, and we'll just name it off like say something like it's a let's a discussion. We'll just keep it like a discussion. Okay, some discussion, right? So one of the doctor has asked me, sir, how accurate are marrow or dams? Say something like dams or marrow. Yeah, marrow grand tests. So he's asking how accurate are these grand tests? See, doctor, each of these sectors, each of these corporates, they say like our grand tests are nearly 96 to 98% is near to the real exam. Okay, but if you say like, for example, I have two scenarios. Previously, I already discussed in one video, but now again I am speaking in this video, right? Because so many doctors are asking me, sir, how accurate are these grand tests, whether it's dams, whether it's marrow, whether it's prep ladder, whatever it is. See, I have two scenarios. I have two scenarios with my students. For example, one of the guy, I don't want to name the doctor. For example, we'll just name it as two scenarios, A and B. This guy of A, he has got a rank less than 5,000 in grand test that was conducted by Marrow, I think. Yes. No. Dams. So he got a rank of 5,000 in the grand test that was conducted by Dams. But in the final NEET PG examination, he got a rank of 23,600. Now, is there any sort of like at least a resemblance between these two ranks? No. Now, I have one more student who secured a rank of 7,000 in the grand test, but he secured a rank of 2,500 like odd, right, in the real examination, real NEET PG examination. Now, by watching these two scenarios, what is your conclusion? I don't want to say it like conclusion. I want to say my opinion is like, see, these grand tests, they will just sharpen your skill of problem solving. Or you can also say like, they will just give an extra edge. Sorry, after a long period of time I'm writing notes, so my writing is a little bit it's like bumpy, so don't think otherwise. Within a short span, I think I will get habitual, right? So these grand tests that was conducted by dams or marrow, they will just sharpen your skill or something like MCQ solving, or they might give an extra edge like, because these grand tests are prepared by the professors who are actually best in their faculties. So obviously they will give the questions which are actually resembling in the pattern wise, not the topic or not the question, right? So you just will we'll just come down. So if you ask me, sir, how much the benefit, it's not about benefit. Please don't think like that. It's not about me. Don't think like Sir is telling negative regarding this dams and matter. No, I don't have any personal agenda against them. But what I am telling is, what is the actual support, or what is the actual gain you obtain from the grand test. So as we already spoken, that is the extra edge feeling. That is, yes, I can solve any type of MCQ, whether it is integrated, whether it is direct, or whether it is tricky ones. And also it gives you some sort of a confidence. But GTs don't decide your rank. Don't think like that. No, 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 no. But I will tell you this one also. But if someone says, listen, for example, if someone says no, wait, I'll just wash it. But if someone says like no, GTs will decide your rank, see, it is just coincidence. Or yes, they will decide your rank, but you perform the same performance in GT as well as the real exam also. But even then, still you can't give any guarantee that you will secure the expected rank. Why? Because, for example, GT is a combination of a bunch of MCQs, but doesn't mean that you will get the question, the topics which were given in the GT will be repeated in the real NEET PG exam scenario. No, you don't have a choice, right? See, it is that this GT, the grand test conducted by dams or narrow, is actually an assumption. It's an assumption. They are expecting it, but they are not confirming it. They are expecting it that this might have, for example, see, let us take like Church-Strauss condition. See, this Church-Strauss, the MCQ on Church-Strauss, it might be given in GT, but it might not be given in NEET exam. And so, for example, the examiners or the professors who had designed this grand test paper of marrow or dams, they might think like, yes, this time you will get a question on say something like, you know, signs of pregnancy. But in the real NEET PG examination, you will not get any MCQ on signs of pregnancy. Then what you will do? Then what is your reaction? See, that is what. See, you should be favored with luck also, right? Sometimes a person of A, he might get all the topics which he obviously knew in the GT, but in the real examination, he might get a topics which he actually left nearly 30% of it. So ultimately, he will become a loser. So don't blindly depend on grand tests. That is what I am saying. Don't blindly depend on grand test. See, for example, you got a good rank in grand test. Say something like you got a nice rank. You got a nice rank means something like you got just make it like 2,500 or at least 2,000 in the grand test. But that doesn't mean you will secure the very same rank or at least a 300 ranks margin in the real NEET PG. No. See, grand test rank reflecting in NEET PG occurs only a percentage of the students who attempted GT. For example, some X percentage of students have attended grand test. So they got, in this total of this X percentage, there might be something like 60% of students only will get their expected rank in PG depending upon the result they achieved in the GT. But not 100%. For example, yes, I have given grand test of so-called, grand test or mock test or whatever it is. I have given GT of dams. So I got something like 3,000 in dams grand test. So obviously I will get something like roughly 500 that side or this side, both ways. I might get something like, for example, 2400. See, 2400 to maybe something like 3600. So in this figure only I will get rank in NEET PG. No, that will not happen. That will not at all happen. No, it might happen for nearly, previously we already discussed, 60% of students can only expect those things. Rest of the 40% they will be getting surprise ranks. Surprise. Some might get ranks beyond the actual limit, and some might get ranked something like a person getting 4 figures in the DAMS GT, he might get 3 figures in the real NEET PG examination. So that is the reason, don't blindly depend on this GT results. They are only to give you some cutting edge skill, or you to just make sure like in which sections you are strong and in which sections you are weak. So these are the benefits of GT. I'm repeating once again, please don't assume like the rank which you get in GT will be reflected roughly nearly 88% will be reflected in the NEET PG examination. No, that is just an assumption. GT tests are exclusively to check your skill, to check your level of preparation. That's it. But just because you got a rank of 1000 in GT doesn't mean like you will be getting something around 900 to 2000 in the NEET PG. No, that will not happen. Things might tumble. Things might tumble means it might become reverse. You got 1000 in GT, you might get 11,000 in NEET PG examination. Chances are there very high. Okay, so please, my one request is never ever assume that you will get this one or that one line. Okay, so we'll just leave it up. We'll just delete this. Right, okay, just we'll leave it up here. So we'll just go to our previous topic, that is thyroid. So we just finished up to anaplastic carcinoma. So I think doctor, you got your doubt clear, right? So please don't depend on those marrows, GTs or DAMS GTs like that. See, I'm saying once again, see, I'm not against to anyone's agenda. Yes, they are great. They are good because they are designed by the one of the best faculties in those subjects. But what you should expect from them? You should not expect rank. No. That is what I am speaking. Don't expect rank from those GTs. These GTs are only to test your skill. And they are just giving an analysis of the topics which you are strong and the topics in which you are actually weak. So you can use those GT's results to just analyze yourself and just say like, okay, I should revise gynec once again because I am weak in so and so complications, so and so cervical carcinoma staging, I am weak, so I should read. So like that, these GT tests are only to check your level of MCQ solving, your level of preparation, all these things, but GTs will not decide your. Okay, so we'll go on with the next topic, that is thyroid lymphoma. Okay, thyroid lymphoma. Thyroid lymphoma, guys, watch my videos completely, guys, because see, rather than going on and mugging up with the revision, you can watch my videos. See, they are all informative. They have all the information that is needed for the exam. You just simply watch it, man. At least you can get a revision. Why to mugging up everything, right? At least you can hear my videos. That will be more than enough. It will become a revision for you. If you have any mistakes, you can go and correct it, right? Okay. Now, remember one thing. Most nodal lymphomas are actually Hodgkin's. Most nodal lymphomas are actually Hodgkin's. While most extranodal lymphomas, see, nodal lymphomas are Hodgkin's and extranodal lymphomas are non-Hodgkin's. Remember, extranodal lymphomas are non-Hodgkin's. Remember. Okay. Now, what is the most common type of lymphoma in a thyroid? What is the most common type of lymphoma in thyroid? What is that? It is non-Hodgkin's lymphoma. It is non-Hodgkin's lymphoma. So, what can you define by this statement? So, most of the times, when you hear a lymphoma regarding the thyroid concept, then obviously it is present outside the nodes, that is extranodal. So because most common lymphomas seen in thyroid are non-Hodgkin's. Okay. Now what is the most common type of non-Hodgkin's lymphoma? That is diffuse. That is diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma. Okay, so that is the most common type of non-Hodgkin's lymphoma. Now, what are the risk factors for thyroid lymphoma? Very easy. What are those? First one is Hashimoto's thyroiditis. First one is Hashimoto's thyroiditis, and second one is chronic lymphocytic thyroiditis. Chronic lymphocytic thyroiditis. So these are the risk factors for thyroid lymphoma. Now what are the clinical features? Now if you just go into the clinical features, we already know that the lymphomas, the lymph nodes are actually involved. We know what's lymphoma. Lymphomas are nothing but there is an involvement of lymph nodes. It is actually a rapid growing tumor which causes a sudden increase in the size and it leads to swelling. So it's a rapid growing tumor which causes sudden increase in the size of the swelling. Now there is a compression that is present in the midline structures which is associated with cervical lymphadenopathy, right? So there will be an occurrence of compression due to cervical lymphadenopathy. Cervical lymphadenopathy. Now compression on which structures? Can anybody explain it? Compression on which structures? What are the structures present posterior to thyroid? That is trachea. Trachea, if it is compressed, what happens? It leads to dyspnea. Esophagus, if compressed, it leads to dysphagia. And recurrent laryngeal nerve, that is called as RLN nerve, if it is compressed, it leads to dysphonia, or also we can determine it as hoarseness of voice, right? Now this leads to dyspnea, dysphagia and dysphonia or hoarseness of voice. Now, what is the differentiating feature? The differentiating feature here, you can determine it like there will be a typically lymphomas, they are actually painless and there will be fever. So typically lymphomas are, remember, lymphomas are painless and there will be fever. Remember, it's very, very important statement. Please, all of you, remember this. Okay. Now, what are the characteristic features of thyroid lymphoma? So, what are the characteristic features which you can easily differentiate an anaplastic carcinoma from lymphoma? So, what are those characteristic features we discussed here? The one is it is painless and there is a presence of fever. Now, if you slightly go to the so-called anaplastic carcinoma, obviously you can't see both of these. You can't see both of these, right? So that is the condition where you can differentiate the lymphomas from anaplastic carcinoma. But what are the similarities between thyroid lymphoma and anaplastic carcinoma. What are the similarities? Wait, I'll just change the color. Why I'm using this color? So what are the similarities between thyroid lymphoma and anaplastic carcinoma? The first one is both are rapidly growing tumors. Both are rapidly growing tumors. And one more thing is lymphadenopathy, presence of lymphadenopathy. Presence of lymphadenopathy as well. There is a compression of recurrent laryngeal nerve invasion by the lymphoma. Obviously, it leads to hoarseness of voice. Right now, first this one is dysphonia. So we have these similarities between, right here, similarities between anaplastic and what is that? Lymphoma. Which lymphoma? Thyroid lymphomas you are speaking, right? So it's a rapid, these both are rapidly growing. That is, there will be a sudden increase in the swelling, right? Size of the swelling in both the cases, and there will be lymphadenopathy and there will be dysphonia. Okay, so with that we finish this concept. Now we come to investigations. Now what are the investigations that we mostly approach? So investigations that can be done in thyroid lymphomas are, as we already discussed, there are some limitations to the FNAC. So thyroid lymphoma is a limitation to the FNAC. Limitation means it can't be done. FNAC can't be done in thyroid lymphoma. So what is the investigation of choice for diagnosis of thyroid lymphoma? It is always biopsy. It's always biopsy. Right. Now if you ask me the treatment, sir, what is the treatment for thyroid lymphoma? It's very simple. It is just EBRT. I'll change the color. Just wait. So many doctors are asking me, so change the color. Yes, I'll change the color. What is the treatment? It is EBRT. What is meant by EBRT? External beam radiotherapy plus chemotherapy. Right? It's given. Now, what is the chemotherapy that is being given in thyroid lymphomas? So here you wrote, so we'll give chemotherapy. But what is the chemotherapy? What are the agents that you give in case of thyroid lymphoma? So we have a mnemonic for that. That is CHOP. CHOP means C, cyclophosphamide. And second one is H for hydroxydonorubicin. Right, rubicin. Now O for anyone, oncoin. That is vincristine, right? Oncoin. P for prednisolone. So in thyroid lymphoma, we give something that is steroid also, prednisolone. Now it's not prednisolone, it's right there as prednisone, right? Now, in case if the patient is having complex symptoms, means even you have done EBRT as well as chemotherapy, but still the patient is having compressed symptoms, what we will do? We will simply go for thyroidectomy, as simple as like that. We will simply go for thyroidectomy. But what will you go only for thyroidectomy, or you want to do something else? You will go for lymph node dissection also. Thyroidectomy plus lymph node dissection. See, it's as simple as that. Okay. Any confusion? No confusion, right? So that is all about thyroid lymphomas, right? So thyroidectomy, we have 6 images in thyroidectomy. We'll be getting those images in the image session. So right now we'll be going on. So in which position? So we will discuss some things about thyroidectomy. So you don't panic. So we'll discuss some things about thyroidectomy. I'll write it here. You just check it down, right? You just tally with your notes or any other resources you have, right? So thyroidectomy, what is the position that you keep the patient in while doing the thyroidectomy? That is called as rose position. That is called as rose position, or you can also call it as barking dog's position. Barking dog position. Okay, so that is called as rose position or barking dog's position. So what is a rose position? Just imagine, listen to my words carefully. Just imagine, right? So in rose position, what we do is we'll just ask the patient to extend his head. You just ask the patient to extend his head. How much? 30 degrees head up, right? 30 degrees, you will ask the patient to extend for 30 degrees head up. Now what we do is we'll just keep some towels below the shoulder blade. Just keep some towels below the shoulder blade. Now what is the advantage of this position? What is the advantage of this position? So the near advantage of this position is there will be a bloodless flow. But what is the disadvantage? Disadvantage is that there will be an increased risk of embolism. Okay, there will be an increased risk of embolism. Okay, just 1 minute, 1 minute. Okay, now what are the details regarding the incision made while performing the thyroidectomy? So what is the type of incision given in thyroidectomy? What is the type of incision given in thyroidectomy? What is that incision name? That is Cocker's transverse cervical collar incision. Cocker's transverse cervical collar incision. Okay, so this is the type of incision that was given in thyroidectomy, and this is the position in which the patient is kept. And what is the advantage of that position? Rose position is bloodless pain. And what is the disadvantage? There is an increased risk of embolism. What is difference between thrombus and embolism? Guys, please 1 minute, guys. 1 minute. 1 minute. Sorry for the disturbance. 1 minute. Okay guys, welcome again. So what we do in this coccus transverse cervical collar incision, right? What is the incision that was done in thyroidectomy? So we just do coccus transverse cervical collar incision. We also call it as KTCC, right? And what is the position of the patient that we keep during thyroidectomy? That is rose position, or also called as barking dog position. See, in some of the examinations, sometimes the professors or the examiners, they might give you with a confusing options, like for example, they will give you jackknife position, Trendelenburg position, reverse Trendelenburg position. With that, they will give you barking dog position. So the image which was given in the MCQ, that is actually rose position, but they won't give you rose position option. They will give you barking dog position. Okay, so don't get confused. So anything might be okay. See the position in which thyroidectomy is performed. So you'll be given all these options: Trendelenburg, reverse Trendelenburg, then jackknife position and barking dog position. So the answer is barking dog position. Don't keep wrong options, right? Barking dog position is the answer. Okay. Now what is the advantage of rose position? It's a bloodless field. And what is the disadvantage? There will be an increased risk of embolism. Okay. So with that, we'll just drop it down there and we'll get on to the next one. So details regarding the incision that we give is coccus transverse cervical collar incision, that is KTCC. Now what we do in that incision, so we give 1 centimeter below the cricoid cartilage. We give the incision 1 centimeter below the cricoid cartilage. So coccus incision is given 1 centimeter below the cricoid cartilage. Very important. Remember, very important. Okay. Now the subcutaneous tissue and the plasma are incised sharply. After this, subplatysma flap will be raised, and after subplatysma flap raisure superiorly, they will just raise those things to superior aspect, right? Inferiorly, what they do is they raise it till up to suprasternal notch. So after this, trap muscles will be incised in the midline and they will be retracted laterally. After that, what we'll do, they will see a butterfly structure, that is thyroid gland. Now what are the final muscles that have to be incised? That will be the MCQ. The final muscles that to be incised are strap muscles. The final muscles to be incised while doing the thyroidectomy is strap muscles. It is done in the midline incision, right? Now they are retracted laterally, you will see the butterfly incision. So before discussing the details of surgery, now let us go through some of the vascular anatomy of the nerve fibers. So I think maybe we might discuss the vascular supply and anatomy in the anatomy itself. So right now we'll just go through the rest of the topics, that is. So we finished this one. I think I'm happy with it. Finish this one. So yes, okay. We'll just give some important aspects, like we'll just discuss about parathyroid gland, right? We'll just discuss about parathyroid gland. Just write down here. It's parathyroid. Just we'll keep it here. So first we'll finish it off, this one. Okay. So how will you identify parathyroid gland while doing the thyroidectomy? So while performing it, we will look onto a golden brown or a canary yellow structure, which is nothing but parathyroid gland. But if you think like I'm unable to identify the parathyroid, so I'm getting some sort of a confusion, what you will do? For example, the parathyroid may look like fat. You might just misinterpret it as a fat tissue. So what you should do? In that scenario, you should first, it should be put into cold saline. It should be kept in cold saline. If it is fat, it will float. If it is parathyroid, it will sink. Now, say something like, if there is an accident removal of parathyroid while performing the thyroidectomy. For example, you are doing the thyroidectomy, you have accidentally removed the parathyroid. Now what you will do, right? We'll just discuss here. Okay. For example, you have accidentally removed the parathyroid. You have accidentally removed the parathyroid. So what are the options that were left to restore the function? So then you will simply, what you do is you divide that parathyroid gland into small pieces of nearly 1 mm size. Pieces of 1 mm size, right? So 1 mm size. Wait, just 1 minute. So you will divide the parathyroid gland into small pieces of 1 mm size, right? 1 mm size. Now what you do is you simply auto transplant the tissue into the belly of whom? The belly of Sunny Leon? No, sternocleidomastoid. Sternocleidomastoid. So you should auto transplant that small piece of parathyroid gland into the belly of sternocleidomastoid, not Sunny Leon. You should transplant that parathyroid tissue into the belly of sternocleidomastoid. Okay. Now, yes, you will transplanted it. That's okay. That's very good. Now, how will you make a recognition to it? You should mark it with a silk suture. You should, this useless one. Okay, mark it with a silk suture. Okay, so that one gives you a recognition mark. So it stays as a recognition mark. So silk suture, non-absorber, or you can use a clip also. Okay, now if a patient has hyperparathyroidism, which is caused due to parathyroid hyperplasia, right? If a patient has hyperparathyroidism, which is actually caused due to parathyroid hyperplasia. Hyperplasia means there will be an increasing cell number. Hypertrophy means there will be an increasing cell size. Remember, okay? So then what you do in such a case, what you do is, I'll write here. For example, right here, a patient has hyperparathyroidism due to parathyroid hyperplasia. So what you will do? You will simply, what you will do? You will remove 3.5. You will remove 3.5% of the gland. 3.5 section of the gland. Right? Now what you will do with the remaining part? Anyone? The remaining part is divided into small pieces. Divided into small pieces. And what you will do these pieces? It will be transplanted into brachioradialis of non-dominant. Of non-dominant. Okay, everyone okay with it? Everyone okay with it? Accidental removal of parathyroid, or to transplant the small tissues of 1 mm size into the belly of sternocleidomastoid, and you just mark it with a silk suture in order for determination. And if the patient has hyperthyroidism, which is caused due to parathyroid hyperplasia, you remove 3.5 section of the gland, and the remaining part will be divided into small pieces, and it will be transplanted into the Brachioradialis of the non-dominant. Now, what is the most commonly used muscle for transplantation? Previously, we already discussed, that is sternocleidomastoid muscle. Okay. For transplantation during thyroidectomy, for patient with hyperparathyroidism, the muscle most commonly used for transplantation is brachioradialis. Okay or not? Okay or not? Or should I explain it one more time? See, sternocleidomastoid muscle is the most commonly used muscle. Okay. Most commonly used muscle if there will be a accidental resection of parathyroid during the thyroidectomy, right? But if the hyperparathyroidism is due to parathyroid hyperplasia, then the muscle that is most commonly used for transplantation is brachioradialis. Okay, understood or not? Yes. So we will get on to the next topic. Now, what are the complications of thyroidectomy? I think we will do it in another page. Okay. So just 1 minute. This will keep like this. Wait. Thyroid. Okay, we'll keep it like yes, you can leave it like that. Okay. So what are the complications of thyroid? What are the complications of thyroid? Anyone? So many doctors are asking me, SAR is just simply going like, yes, so what is the problem in it? Do you have any problem? I'm simply going, I'm just flowing with my flow. That's it. Because, see, that is what it says.